Hi everybody, thanks for taking the time to listen to this recording. I just thought it was a nice different way to provide you with some updates that are coming about as of October 21st, some of the changes that have come into CTAS as well as what's going to be changing within Connect Care in relation to your triage assessments. Just to give you some update as to why we are making some changes to CTAS, the original work happened in about 1998, and there actually wasn't an availability of an actual educational tool across the country until about 2003, 2004. There was a major update that incorporated pediatrics into CTAS in about 2012. And then in 2016, there was a small addition of adding the frailty modifier, pregnancy, and mental health modifiers. And these weren't well adopted across Canada. I think here in Calgary, I think we were using them, but across Canada, they definitely weren't. So there was a definite need to kind of relook at CTAS. There is a big break between 2016 and 2024 when Nina and Cape, which is our emergency physician colleagues within the National Advisory, came together again and said we need to update not only CTAS but update the educational materials. And that is where we are coming at you guys from today. Now, triage is a process, and across Canada, we have adopted CTAS as a standardized set of guidelines to help facilitate triage in all emergency departments. So it really is intended to give a tool to those triage nurses to make the best acuity score for those patients and help them to prioritize. So what we have done and making sure that your education is the same and that the tool within Connect Care is also there to help support you in making sure you make the right decisions. So that's why we want to provide some extra education just to remind you about why we have these tools and the importance of making sure that we use the tools you have available to you to make the best and most informed decisions. Just to put your mind at ease for all the changes, one thing that has not changed is the CTAS process. Nothing is different with this in the sense that it's still continued to be that critical look. We're doing our infection prevention and control, our triage assessment, choosing a complaint, using our modifiers from our primary modifiers and our complaint specific, assigning a score and reassessment. So that has not changed and that work will continue forward. One of the changes that you're going to notice that has occurred within the CTAS is actually just around language. One of the things we used to talk about is, if you remember your education, they talked about first order modifiers. That has now been switched over to be called primary modifiers. These have always incorporated things like airway breathing, circulation, disability, which in the emerge language world, those are primary assessments. So why not call them primary modifiers? So that's one big change you're going to notice. The other one is the education used to talk about second order modifiers. That was confusing. So at some point in 2016 or 2012, it was called special modifiers or special order modifiers. And that still was confusing. So we've basically taken it from a national level and actually chosen to call them complaint specific because that's what they are. They are those red flags with your chief complaint, those things you should question. What would make a particular complaint a CTAS 5? Or if they come presenting slightly different with the same concern, they might be a CTAS 2. So really they are what they are. They are complaint specific modifiers, so that language has changed. The other thing you're going to notice when you go through your CTAS training or when we look at Connect Care is some of the reorganization of the CTAS complaints. So one of them is sexual assault. If you guys remember, sexual assault was kind of always considered to be an OB-GYN complaint, which was really kind of not appropriate, which kind of implies that sexual assaults could only occur to females instead of more appropriately across the gender spectrum. So sexual assault itself is actually now under the trauma category rather than an OB-GYN category. The other good thing is if under trauma, you will also find all your trauma related stuff. So head trauma, chest trauma, abdominal trauma. Instead of them being under the other categories, all of your trauma related complaints will also be under the trauma category, which is super nice. The other reorganization is the concern for patients' welfare. This one used to be housed under the mental health complaints, when in reality you can have lots of reasons for patients' welfare that are not mental health related. You might have them, a concern because they're, being left at home, their caregiver isn't able to support them. That's not really a mental health concern, so it really falls more under the general concern. So just some reorganization of them, which you may or may not appreciate when you use them because you just know where to go find those chief complaints. But they have definitely changed within the larger national level. where you're going to notice some of the biggest changes actually in the modifiers. So we've actually added one new primary modifier. So we said primaries were airway, breathing, circulation, disability. What we've done is move frailty up. Frailty's always been there for us here in Calgary anyway since 2016. However, we've moved it up into the primary modifiers just to make sure it's not getting missed and overlooked. The other thing we've done is there's 5 of the CTAS complaints have a new lowest possible CTAS score. So when you choose a particular complaint, it might be the lowest possible score is a 5, and then other things might bump it up. But we've changed about 5 of them. So one of the examples is under confusion. The lowest possible CTAS score used to be for confusion a CTAS 4. It is now the lowest possible if you choose confusion as a CTAS 3. The rationale for that is that a CTAS 4s and 5s are supposed to have normal vital signs. So how can you have a normal vital sign but be confused? Because that's a GCS of 14, 13. So it didn't make sense that it was a CTAS 4, so that's moved up to a CTAS 3. The other one that's changed is for the CTAS complaints had primary modifiers completely removed, which is interesting because why would you have a removal of primary modifiers? But some of this is because some of the modifiers should be so stable. You should only select them if the patient's so stable. You shouldn't need primary modifiers. One example is direct referral for consultation. Your direct referral for consultation is intended for a very stable patient that is coming in just for consultation. If their vital signs are outside normal, like they're tachycardic, they're febrile, they have an acute pain of 10 out of 10 or whatever, they probably should be triaged under a more appropriate CTAS complaint than direct referral for consultation. The other thing that's happened is 6 of your CTAS complaints have actually had primary modifiers added. Surprisingly enough, certain things that, such as a wound check, never used to have primary modifiers, with the assumption that they should be stable. However, what we find is that wound checks come in, maybe they've been seen 2 or 3 days ago, now they're coming in febrile, maybe have signs and symptoms of sepsis. So primary modifiers have been added to make sure that we're not missing some of these wounds that actually might be unwell. So those have been added in. The other thing that has been done is that 85 complaint-specific modifiers have been removed. These were ones that were mostly redundant, so you're not going to miss too much about that. But more importantly, 244 complaint-specific modifiers have been added. I can't possibly even start to tell you which some of these are. We're going to go through some of them, but one is under laceration and punctures. If you go to there's actually an option now to say with partial degloving injury is a CTAS 2. That never used to be there. If you go to substance misuse and intoxication, it kind of ended up being a 3, and then you were left in limbo if something, maybe you're like, well, actually, I don't know if it's a 3, if it's a 2. What has been added is an option for a CTAS 4 under substance misuse that is a known pharmaceutical drug within therapeutic dosages. So again, there's good information when you do the actual full CTAS course to kind of go into what does this mean. But it's again just kind of expanding some of the modifiers to make your judgment a little bit more clear. We should all remember our frailty modifier, and like I said, one noticeable difference you're going to see is it actually shows up under primary modifiers. A typical patient that we have coming in for frailty would be that over 88 patient. If they are not, unless they're physically, super robust, they're going to be minimum CTAS 3. We are also looking for those patients that are frail, wheelchair bound, depend on others for their ADLs and that kind of stuff. So it just allows us to make sure they don't fall through the cracks, minimum CTAS 3. One thing that I think the national group also kind of came about was considering those other ones that might be at risk for extended waits in the waiting room. These might be ones that are there left alone that maybe don't have support centers. Maybe these are our unhoused population and this is their only way they've come in for care. If they do leave without being seen due to an extended wait, it actually could significantly impact their health because they don't have a place to go. So consider it for those vulnerable populations as well, that you can make them a CTAS 3. The other thing you're going to notice here is that there's an option for a CTAS 2 in your frailty modifier. This is to help us cover, we've always have said that a child, a baby coming in that's less than 7 days old should be minimum CTAS 2, but it was kind of hard to navigate around that within Connect Care. So now it is automatic. If a patient comes in, you've triaged them as a infant under the age of 3 months, you will have the option of, hey, should we make this patient a CTAS 2 because of their vulnerability, because of their young age and because they're immunocompromised. So the reason why it's under 3 months is because under 7 days should be automatically a CTAS 2, but we have to age correct it for those premature babies. So we're basically, for babies born less than 37 weeks gestation, you have to consider that is actually how old they are. So it's not the day they were born, it's actually how premature. You have to start kind of working that back. So just consider that for your babies that are premature, or premature or within that 7-day window of delivery, that they should be minimum CTAS score of a 2. All right, so now the exciting news is that's all. There's tons of stuff in CTAS, and how are you going to know it all? But really what's going to be exciting is how this is actually going to be reflected in our Connect Care that we are going to use on a day-to-day basis. These changes are going live on October 21st all across the province. Just a quick reflection on where we came from within Connect Care and how CTAS was kind of laid out. If you guys recall, we always had to do it kind of 2 steps. There was a chief complaint step, and then you would go down and then you would have to go into the CTAS step in order to choose your primary modifiers, your complaint specific modifiers. What I always found frustrating was if I needed to change my chief complaint, I had to leave this, go back up to chief complaint and change it. So sometimes it was a bit more confusing, and there was oftentimes we found staff were actually missing things because they were in a rush. They would hit chief complaint and maybe forget to go and select CTAS. So 2 steps always seems like a lot, especially when we are on the computers all day. So there are some improvements. My favorite part of the new build is instead of making it 2 steps, it's now 1. So you no longer have to go into that chief complaint in the ED assessment. You can just go right to CTAS. So within CTAS, and those of you that used SCM, you will recognize this and hopefully be really happy to have this back. But you can go right into CTAS. And when you go into CTAS, all of your complaint categories, there's still 17 categories to choose from. All of your categories will be there. Once you select a category, then down below is going to drop all of the chief complaints that are within that category. The thing I love about this, and as I was kind of just showing staff about this and triage nurses about this a few months ago, they're like, well, I didn't know that that chief complaint existed. Oh, I forgot about that one. I always use general or minor because I didn't even know that existed. There is so many chief complaints. I think there's 176 chief complaints. There's no way that you're going to memorize them all. So this is such a great tool. You're like, okay, it's GIGU, let's go in. You can go right in that CTAS complaint and actually open up different categories if you want. You can kind of hunt around for what would be the most appropriate chief complaint when this patient's presenting. So it just is, I think, really a great way for us to communicate to our colleagues better, as well as choose the most appropriate acuity score for our patients based on a really validated chief complaint. The second upgrade that you're going to notice is once you're in that CTAS score, so you've got your category chosen, you've chosen your chief complaint. Once you choose your chief complaint, it automatically will drop down and present to you your primary modifiers and your complaint specific. We've asked Epic to give them a bar, so they've made these purple and blue bars just to demarcate for our eyes. We get so much overload looking at the computer, but it will really demarcate it for you that you can see those primary modifiers. They are all underneath there. And then you can look down, you're like, yeah, those are good. And you can go down and really highlight and look at those complaint specific modifiers and say, do any of these matter to this patient? Are any of them pertinent? Just kind of gives it all on one screen. You have absolutely everything you need to do from CTAS instead of having jumping back and forth between chief complaint and CTAS and all that stuff. So it really makes it a nice, easy to use tool. Now, I know you guys all remember that your primary modifiers will always change your CTAS score, but your complaint-specific modifiers will be dependent on what you choose. So this is just a really great example here that you will actually see that you've got a no primary modifiers were chosen just because I wanted to make sure you guys saw it. And it technically was started off as a CTAS 4, I think it was, but you've chosen that actually complaint specific modifier, and it will provide you with the recommended acuity score of a CTAS 2. So again, it is not only just to help give you direction for maybe questions to ask your patient, but it also gives you direction on that this is actually considered a red flag and the appropriate acuity score for that particular concern. So all of these changes are great, and if we can, minimize the number of clicks we have to do, all the better. So it will require you to do a little bit of adjustment to your triage flow and actually go into Connect Care and adjust under your ED assessment that triage section so you don't have to kind of figure out where you want to go. Right now we kind of ED note, chief complaint, or vital signs, pain, and then CTAS. You now can actually take away the chief complaint and kind of just hide it down below. So you can do a modification of your layout in order to adjust this, and I'll have posters put at triage to show you how to modify your layout if you've forgotten how. Other than that, now we can go under our ED note, open it, have it off to the side. This is where we're going to have our narrative discussion about your patient concern, significant past medical history and your condition of your patient. It's really a great communication tool amongst your team members at triage and in the back regarding priority and flow. And it's nice because you keep it open as you're kind of getting the rest of your triage process done. You want to make sure you do vital signs and pain next, because those actually they will filter in and trigger your primary modifiers within CTAS. So you want to make sure that those two are done prior to going into the CTAS. Of interest, because I get asked this quite a bit, is why are things being triggered? The parameters that are built into Connect Care, also supported by CTAS, for abnormal vital signs or any heart rate greater than 92. If your systolic blood pressure is 90 or less, if a respiratory rate is greater than 22, or your SATs are less than 90, and less than 90 is going to give you severe respiratory distress, and I think it's less than 92 will give you moderate respiratory distress. These all trigger the primary modifiers in Connect Care and say they're abnormal vital signs. We're going to talk about that in a second. Pain is the other one. And then after you get to that, you're going to go into your CTAS. And the great thing now is it's all in one. You can choose your complaint category, your chief complaint, and then go into your primary modifiers and your complaint specific modifiers all on one screen. So I think it just is, number one, saving us click and some of this computer fatigue we get by having to do this every day. All right, I know you guys are already asking questions, so I was thinking up some common questions. So first of all, based on those vital sign modifiers that I just told you about, they're going to trigger things like respiratory distress and that kind of stuff. Can you unselect a modifier that is automatically triggered if you don't feel it is representative of the appropriate CTAS score? So in this situation, I actually put in some vital signs for your patient of a pulse of 92, blood pressure was 100 looks like, and my SATs were 91%. You will notice I haven't even chosen a chief complaint, and the CTAS module, or the module within Epic, is already making them a CTAS 2. They believe that based on that, I think it's probably my SAT of 91%, the patient's already in moderate respiratory distress, and based on the fact that he's got a slightly, soft blood pressure and a pulse of 92, it's telling me that my patient is hemodynamically, I think, vital signs outside normal limits. So you now as a triage nurse, these are just triggers. They're little things to say, hey, what did I miss? Maybe you put the vital signs in, maybe somebody did the vital signs for you, maybe you didn't connect them. Whatever it is, it's just to say, hey, does this patient have respiratory distress? Do they warrant a CTAS 2? Again, if they are looking acutely like they actually are working at breathing, then absolutely keep it. If forever it's like, oh, actually the patient came in, they just walked from the car, their SATs are fine, their fingers are cold, whatever it is, you can go ahead and unselect those. So I show that below that maybe you want to move them from moderate respiratory distress to mild. So they're a little short of breath because they walk from the car. They maybe are COPDers, they normally never get better than 92%. That you can go ahead and unselect the modifiers or readjust them to the more appropriate modifiers to get to this appropriate CTAS score you require. The other common question is, what about my pain scores? So you got that patient that shows up to triage and they say their pain's a 12 out of 10, but they're drinking their coffee, they're on their phones, they're walking, they're not hunched over, they don't you don't have the perspective. They're not tachycardic. They don't look like they're in pain, but they end up being a CTAS 2 because they stated their pain was 10 out of 10, acute central. Well, we've got some clarification from NINA and CTAS from a national standard that if the patient states their pain is one thing, but your assessment, such as 10 out of 10, but your assessment doesn't support that in the sense of they're eating, drinking, looking fine, you are allowed to and supported to decrease that pain score by 1 CTAS score. So the big example is their acute severe pain, 8 out of 10. Their 10 out of 10 makes them a CTAS 2. However, you're looking at them then feel that you could drop it. So you can actually just unselect that 8 out of 10, reselect the acute 4 to 7 that would provide them a CTAS of 3. So you are supported, and there's documentations to support this at a national level. Be careful though, and just be thoughtful about some of those acute pain crises or those weird pain situations when the pain is disproportionate to why the patient's here. These are those ones, such as our sicklers. Our sickle cell patients they're going to have acute pain. They are an acute pain crisis, but they've learned coping strategies over their entire life to manage it. So they may not have the same look that some of our other patients in acute pain might. So be cautious about underscoring them. The other ones would be your compartment syndromes and neck fash. Those are disproportionate to what you see, and that should be a big red flag to you that they actually probably are something more critical and probably need to be a CTAS 2. So you are supported to do it. Make sure you document in your narrative. You're still going to state the patient's pain as 10 out of 10, but in my narrative, patient states pain 10 out of 10, walking, eating, drinking, refused Tylenol, whatever it happened to be, and just making sure you've covered yourself in your narrative documentation. This is another common question that I think I answer at least once a week, and this is always about our EMS patients. So our EMS patient sees a patient at home, they get their SATs at 86 at home, they give them a neb, they put them on a couple of liters of oxygen, and by the time they get into the emergency department, their SATs are sitting at 95, 96%. They look in no distress whatsoever, but according to our respiratory distress definitions, which we all have remembered from our CTAS course, if their SATs were less than 90%, they're supposed to be a 1. So do they have to be? Well, it's not necessarily. So really, and there's a tiny little thing, I'm not sure if you can see it, I've got the arrow pointing to it, is always correlate your clinical picture with the oxygen saturation levels to choose your CTAS score. So I would be cautious about, number one, when you have a EMS patient arrive, we should be triaging what you see in front of you. Therefore, you're entering the vital signs you see in front of you. Their vital signs are put on their documentation. You are going to have a new set of vital signs seen in front of you. So let's say it's a SAT of 95, 96, respiratory rate of 20, whatever that turns out to be. That is what you are documenting. You are going to document in your notes that the EMS found and or treated this lower oxygen saturation rate. And now you need to just look at your patient. So are they looking like they're in severe respiratory distress? Are they fatiguing? Are they single word speech? Are they really looking like they require assisted breathing or lethargic, confused, and we might need to intubate them? And if they're not, they probably don't need to be a CTAS 1. If their clinical picture looks more like, let's say, a mild distress and they're a CTAS 3 based on your clinical picture in front of you, what I would do is then just take into consideration that they were sicker at home. Is there a high risk for deterioration if they're sitting in our EMS hallway waiting? They're going to be in an oxygen tank sitting in there. So maybe what then you need to do, if your appropriate acuity score shows up as a 3 in front of you, you may just want to override that and bump it up to a 2 based on presenting history of risk of deterioration while in the waiting room. So if you feel that the patient can go down the hallway and not being seen immediately, then they probably shouldn't be CTAS 1. The kind of the association I often put with this when I talk about it is your seizure patient. EMS finds a patient who has a seizure at home. They bring them in, your patient is now postictal, and they're talking to you. If you recall about seizures, if somebody's actively seizing, they're CTAS 1. If they're postictal and still obtunded, they're a CTAS 2. And if returned to their normal baseline with a recent seizure, they're a CTAS 3. So why would I triage them as a CTAS 1 just because they had a seizure at home? Now, there's lots of nuances, multiple seizures, status epilepticus, totally get that. However, the simple fact is we don't triage what EMS found at home. We triage what's in front of you, but you're going to use your clinical judgment and assess your patient on what the appropriate CTAS score is and take that low SAT into consideration in your triage when the patient arrives. All right, another question is, do I need to use the complaint-specific modifiers if I already get the CTAS score I needed? So in here, we're actually talking about a patient. We talk about genital urinary was my category. I went under general trauma. Let's say his vital signs were relatively fine. He was probably complaining of pain. I'm assuming he was they, or I shouldn't say he, but they were going to be complaining of pain. And really that basically one is going to be a minimum CTAS of a 4. If you left it at this, completely taking away all my primary modifiers, that patient is going to have a minimum CTAS of a 4. If we look at our complaint-specific modifiers for this patient, though, there's some of the things that I really find interesting. And so don't just use them as, oh, I don't need that because I have my modifier, but you may also want to be asking some of these other questions. So one of them is just recent history of trauma, but there's also sexual assault in here. And you're like, oh, did I even think to ask? Like, how did you get the trauma? Maybe this is a situation where you need to dig for that question. And then there's also the one about it's a concern for a decreased blood flow due to some application of a device. So I didn't even think to ask that question. So sometimes your complaint-specific modifiers might help direct your questioning or your assessment of your patient as well. In this particular situation, if I did choose that one, it actually does make my patient a CTAS 2. So even though vital signs may not have made that patient a CTAS 2, in this situation, I'm assuming pain likely would have. However, the complaint-specific modifiers can completely override looking for some of those red flags. So absolutely nothing should delay triage. If your patient is super, super sick, go ahead, get that chief complaint in and go override them to a CTAS 1 and get them to the care that they need. That is not what I'm saying. But when you are assessing your patients to sit in the waiting room or into EMS hallway, looking at those just to make sure you're giving appropriate acuity scores, because the complaint-specific modifiers will help you kind of weed through some of those red flags. That's a quick summary of some of the updates that you guys are going to be seeing over the next little while. I just wanted to let you guys know that, as we mentioned, the CTAS course itself has also been updated. We have been running it for new triage nurses since June of this year. And anybody that's interested and currently a triage nurse, you're more than welcome to join any existing CTAS courses that are being run. I'll be posting some dates for that in the next little while. Do encourage you guys to come out to kind of maybe rethink about CTAS, get some of the new education in much more of a expanded format than what me quickly talking here, but we'll be putting out some of those dates soon. Some of the other future improvements that you're going to be seeing, hopefully over the next little while, one specifically into the EPIC training or the EPIC environment, is they will be creating a specific triage note for us. So instead of having to do an ED note and then type in triage and then it's not the right hovering one when we go over the trackboard, they will be creating a specific triage note for us. So it'll be nice and easy to find out what the triage note was compared to the initial bedside note. And there will be some work being done at a national level again, still to kind of continue to work on CTAS in general, the education, as well as starting to look at some of those CTAS complaints and see if they all still are valuable and speaking the language of what we need in this current day and age. Just always encourage you guys to, as you review this and start working with the new tool in Connect Care, if you have any suggestions for improvements, you notice any bugs or things that might not be working correctly, any concerns or suggestions for improvement, please just reach out to us and let us know, and we're always happy to take those forward. Thanks again for listening. I appreciate your time, and I look forward to seeing you on the floor.